So today I am going to discuss about the hematology. This is my part 3, and I was talking before about the lead poisoning. Today I will talk about the iron deficiency anemia. Before I will talk about this, just let's see, give me the list of the different disease based on the mean corpuscular volume. So we already discussed about the if you found mean corpuscular volume is below 80, so we are thinking patient could have iron deficiency anemia, lead poisoning, sideroblast anemia, thalassemia, and anemia of chronic disease. All of them will have low reticulocyte except the thalassemia, and all of these will have reduced synthesis of the hemoglobin. Heme synthesis is low, and that cause the cell will be small, hemoglobin will be low in amount. Next, give the list of the normochromic normocytic anemia. Mean corpuscular volume is in normal range 80 to 100. It could be sickle cell anemia, it could be hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiency, paroxysmal nocturnal hemoglobinuria, drug-induced cold agglutinin, autoimmune hemolytic anemia, chronic disease, acute bleeding, like say trauma, hypersplenism, like say someone has a block and then the spleen will be big, then blood will be start storing on there, and then the spleen will start breaking down the red blood cell. Microangiopathic hemolytic anemia, like say have injury in the blood vessel, for example the hemorrhagic E. coli release the toxin that can cause. So microangiopathic hemolytic anemia, for example thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminating intravascular coagulation, TTP-ACUS, DIC. If all of this will break down the red blood cell, so indirect bilirubin will increase, and increase the lactate dehydrogenase, reticulocyte count will increase as a compensation, and haptoglobin, because of breakdown of the red blood cell, release the hemoglobin, and haptoglobin will be decreased. And if you look at the peripheral blood smear, we will find these cystocyte and helmet cell. So list of the normochromic normocytic anemia, sickle cell disease, hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiency, paroxysmal nocturnal hemoglobinuria, drug-induced cold agglutinin, autoimmune hemolytic anemia, chronic disease, acute bleeding, hypersplenism, microcytic hemolytic anemia, like thrombotic thrombocytopenic anemia, hemolytic uremic syndrome, disseminated intravascular coagulation. And mid corpuscular volume is greater than 100. Macrocytic anemia can cause by vitamin B12, folic acid, and aplastic anemia like bone marrow myelodysplastic syndrome. Fanconi syndrome is called the congenital marrow dysfunction, and Blackfan diamond syndrome, also called the congenital marrow dysfunction, alcoholic liver disease, myelodysplastic syndrome, all of this can cause the macrocytic anemia. So microcytic and macrocytic anemia, all of this has reticulocyte is low. In normocytic anemia, all of them has reticulocyte is higher except anemia of chronic disease. So anemia of chronic disease can cause normocytic anemia, also microcytic anemia. Why the red blood cell look red? Because it have the iron. When globin can properly bind with iron or lack of iron cause the hypochromic anemia, because iron, without iron, red blood cell will not get red. In normochromic normocytic anemia, why people have anemia? His reticulocyte is normal, even higher, because his lifespan of the red blood cell is not 120 days, shorter. Lifespan of the red blood cell is shorter. That's why it can cause the anemia. Now I'm going to talk about the iron deficiency anemia. Iron deficiency can cause the microcytic hypochromic anemia. Is reticulocyte will be low, mean corpuscular volume will be below 80, and because this person has anemia because of low production of the red blood cell. And anytime any people are taking, like say the older people complaining about the ongoing pain, and he is taking an SAID, non-steroidal anti-inflammatory drugs like ibuprofen, and you are thinking this guy probably is losing blood, and which may cause this guy has iron deficiency anemia. Iron deficiency cause the impaired synthesis of the hemoglobin. So this is a kind of hemoglobinopathy. Sickle cell disease, thalassemia also have problem in the impaired synthesis of the hemoglobin, and all of this has hemoglobinopathy. Now talk about when you thinking the guy has iron deficiency, and a lot of things can cause. And so good history taking is the best thing to approach when someone come to the office of the doctor office, and doctor is thinking this guy could have iron deficiency anemia. And for example, child could have malnutrition, he's just drinking milk doesn't have enough iron. Someone have malabsorption and at the GI tract, and mother is only breastfeed the child the pregnancy, but not increase the demand of the iron, but mother is not taking enough iron. Someone is taking non-steroidal drug and he's here and SAID like ibuprofen, and this person has chronic blood loss that can cause iron deficiency anemia like GI bleeding, excessive menstrual bleeding, etc. Someone is hemolysis and too much the hemoglobin on the blood, haptoglobin cannot take care of this. This person can lose iron through the kidney. Or child have macular diverticulum, polyps, peptic ulcer disease, hookworm. This can cause blood loss and cause iron deficiency anemia. Or child is only drinking the cow milk without the iron supplement, that can cause also iron deficiency anemia. If a newborn before the age of 1 he is drinking cow milk, these kids can develop, the infant can develop milk protein allergy. The milk protein allergy can cause the occult intestinal blood loss. So recommend to the mother that not to give cow milk before the age of 1 to the infant. After the age of 1 is more safer to give the cow milk, but should not be give more than 20 ounce because it doesn't have enough iron. And if just depend on the cow milk without iron, so kids can develop iron deficiency anemia. Premature infant can develop iron deficiency anemia if mother only give the breast milk and the premature infant is less than 36 week of gestation age. He can develop iron deficiency anemia within 3 months if no if no extra iron will be given, but if the premature child is only depend on the milk. And in normal man or menopausal man or the before menopause, usually we need 1 to 2 gram of iron a day. Mother childbearing age, she need 4 gram because she has monthly period. So history of this can give us hints that nutrition and losing blood and malnutrition and all these things can cause the iron deficiency anemia. And clinical symptom of anemia is all of this is almost same. What I talk about all the list, macrocytic, microcytic, normocytic anemia, but each disease like the iron has some particular symptom, lead poisoning has some particular symptom on there also, but anemia caused by all of these will almost show the same symptom like the syncope, shortness of breath, this kind of thing. All of this disease will be most of the time show the same symptom. And someone have iron deficiency anemia with the symptom of anemia. The patient also could show gastritis, glossitis, inflammation in the tongue, inflammation in the GI tract. Plummer-Vinson syndrome is like the esophagus, upper esophagus will have cover. The child anemia depend on, it could be mild, it could be moderate, it could be severe. Usually if hemoglobin level go below 4, we call is kind of severe, and his cardiac output would be increased to meet the demand to supply the oxygen, and child could have anorexia, lethargy, irritability, fatigue. So child symptom could be mild, moderate, and severe depend on the hemoglobin level. But before even until the hemoglobin will not go below 4 and no child is not showing any symptom, we are not going to do anything. If it be below 4 show the symptom, we will easily give him packed red blood cell. Child with iron deficiency anemia, I will talk with it later, they can show they could eat like unusual thing, eyes, dark, paper, we call it pica. I will talk about it next time. And in a physical exam, someone have iron deficiency anemia, he have spoon-shaped nail, we call coelonychia, beetle nail, glossitis, pica. So we already talked about the glossitis and pica. Some child even could have splenomegaly. So because he has anemia, he can develop tachycardia because his oxygen carrying capacity is low, heart try to be compensated, so he could have tachycardia and also tachypnea. And we could heard systolic murmur due to because the cardiac output will be high, and if we put the stethoscope in the second intercostal space over the pulmonary artery, we could hear the systolic murmur, someone also call the flow murmur. If it will go like this, a lot of blood is coming to the heart could be dilated, and finally heart failure could occur. And this is, I'm talking about the physical exam, and you will look at the conjunctivitis, it could be fail, and he could have systolic murmur, tachycardia, tachypnea, some cases even splenomegaly. It's a spoon-shaped nail, beetle nail, and the tongue will be glossitis, and he can have history of the pica, like he was trying to eat the eyes, dart and pepper, all kind of unusual thing he will eat. And diagnosis of the iron deficiency anemia, based we do the laboratory test. First one is, before we said we are thinking he is a failure and he is thinking he has anemia, you are just going to test his hemoglobin hematocrit value, and here when you take the history, it can give you some kind of hints. If you think he look pale and you thinking he may lose blood, so in this case better to do, because it's easy to do, right, to pick a local blood test before we will do it. We will measure the hemoglobin hematocrit value to make sure he has anemia. But person look pale and his history is taking, like say he's taking ibuprofen, or he has problem, some kind of symptom of macula diverticulum, peptic ulcer disease. And so next thing, before we will do hemoglobin hematocrit value, we will measure the fecal local blood test. If this is positive, this person is losing blood through the GI tract, which is the case causing the iron the deficiency anemia. And in this case we will order for, after that we will order for CBC and like say hematocrit, hemoglobin W, and we will also do the colonoscopy, because we already find the blood in his stool. Definitely he's losing blood, and we have to look for the source, where is the blood coming. And if fecal occult blood test is negative, still we will not give up that he may not lose blood in the GI tract, but he could lose blood in other place. And also we will take more history about the malnutrition, like say premature child, gestation age is below 36 weeks, and mother is only giving the infant only the milk, and these kids can develop malnutrition, low sources. He's taking less amount of iron, that can cause iron deficiency anemia. So we did the test for hemoglobin. After we found that fecal occult blood test is positive, we did the CBC and hemoglobin test. We found the red blood cell decrease, reticulocyte also decrease, and in the CBC we found white blood cell in normal, thrombocytopenia could occur or even could be normal, hemoglobin low, mean corpuscular volume is below 80. In peripheral blood smear we find hypochromic microcytic anemia, also you can say microcytic hypochromic anemia, because without iron his red blood cell have less pigmentation, and he also could have anisocytosis, folliculocytosis, and red cell distribution width will be higher, because he has iron deficiency, and he have producing different type of shape of cell, and so his anisocytosis will be higher, and also shape and size both will be higher than red cell distribution with mean corpuscular hemoglobin will decrease, mean corpuscular hemoglobin concentration also decrease, total iron binding capacity will increase, transferrin has more capacity to carry the iron, so saturation of the transferrin is low, capacity to carry iron by the transferrin will be higher. And after we found his hemoglobin hematocrit low, mean corpuscular volume low, below 80, reticulocyte is low, total iron binding capacity is higher, transferrin saturation is low, we will go to test for now serum iron level, and we will found the serum iron level is low, so we confirm that this person has iron deficiency anemia, his ferritin is low, and anemia of chronic disease also has a low iron, but his ferritin will be high. His hemosiderin will be high. Anemia of chronic disease, hemosiderin will be high. Iron deficiency anemia, hemosiderin will be low. If we do the bone marrow biopsy, usually we don't do this. So serum ferritin, only remember, if anytime lab shows serum ferritin is low, right away you have a diagnosis that a person has iron deficiency anemia. In other case, serum ferritin will be not low, it could be high or normal. So if this person have iron deficiency anemia, same time inflammation is going on, let's say he is taking the ibuprofen, you are suspecting he is losing blood, and you are suspecting he has iron deficiency anemia, and same time he has inflammation going on, infection going on, and you do the blood test for ferritin which come higher, and but you are suspecting he has history tell he could have iron deficiency and your ferritin is high. So in this case we will do the bone marrow biopsy to see if his hemosiderin is high or low. If this person has iron deficiency anemia, he has same time infection going on, his hemosiderin will be low. But if this person has anemia of chronic disease, his hemosiderin will be higher. So in the peripheral blood smear, we will see iron deficiency anemia have microcytic anemia, hypochromic, and anisocytosis, poikilocytosis. So anemia due to the iron deficiency anemia, patient could have hypochromic microcytic anemia. His bilirubin will be normal because he is not breaking down any red blood cell. So usually in bone marrow biopsy we don't do for iron deficiency anemia. If ferritin level is below normal, iron is normal, means all of this is a good enough to tell us person has iron deficiency anemia, and serum iron will be confirmed he has iron deficiency anemia. We are not going to do the bone marrow biopsy. So only we will do the bone marrow biopsy in two cases. One is person has iron deficiency anemia, same time he has infection going on, you did the blood test, ferritin come high, so you want to make sure this guy has anemia of chronic disease or he have iron deficiency anemia, because iron deficiency anemia with infection ferritin will be high, anemia of chronic disease ferritin will be high, iron level will be low. So we already talked about iron deficiency can cause anisocytosis. Let's just mean red cell distribution which will be greater than 20%. Poikilocytosis, because as the iron level go down, red blood cell will progressively becoming smaller because the less of hemoglobin it can able to produce, and iron cell, without iron blood cell will be smaller and smaller and smaller. So what will be the treatment? How you can treat this person who has anemia? We give the oral ferrous sulfate. We already know he has iron deficiency anemia, and we give him ferrous sulfate. If this person cannot absorb through the GI tract like duodenum, or he cannot tolerate in orally, and this person has very low serum of iron but has severe symptoms, we can give him iron intravenously, but most of the time we will try to give him iron orally if symptom is not very severe or not very low serum iron and not very severe symptom. The infant could have microcytic anemia, and you're giving him iron. You're thinking he's losing blood and he have macula diverticulum, peptic ulcer disease, and he have protein allergy, milk protein allergy, but you give him iron and you found it didn't make any difference. So what are you thinking the next thing you can do to find out the child have iron deficiency anemia? He could have a problem in the kidney, so erythropoietin is not producing. If you have a kidney problem, we can measure the bunin creatinine, and it can tell he has a kidney problem and he's not producing enough erythropoietin. Or he has constantly going on GI bleeding, which can cause the iron deficiency anemia, or he has hereditary anemia. He's not iron deficiency anemia. Some genetics problem is giving him microcytic anemia. Usually to the child we don't give any packed red blood cell. We give red blood cell to the older people who has, for example, arteriosclerosis disease, a blood vessel in the heart is getting smaller and smaller, and so in this case we have to try to keep his hematocrit value over 30%. And otherwise, if the child has hemoglobin greater than 4, we will not give him anything. He is not showing any symptom, we are not going to give anything, only we will give him ferrous sulfate. So ferrous sulfate we can give orally if it be not very severe case. We can give intravenously if you have a very severe case. You cannot take iron orally in this case. And child case in microcytic anemia, we can give him iron because we are thinking he is losing blood and he is not taking enough nutrition. We are giving him, and we found if it be malnutrition, he will respond. If it be not malnutrition, he will not going to respond. Probably in this case we have to go to look for what other thing can cause he has iron, he has microcytic anemia. For example, if he has a kidney problem and his bunin creatinine high, that gives us hints that he has a kidney problem. Probably he is not producing enough erythropoietin, that is causing his not to produce enough red blood cell, or he has losing the blood, or he has inherited any genetics problem, hereditary disease that can cause the anemia. And as it said before, hemoglobin is greater than 4, no symptom, we will not do anything. He has a symptom, we'll go fake red blood cell. His hemoglobin is, he's a child, his hemoglobin is less than 4, we will give him fake red blood cell. If this child has pica, he's drinking he's eating ice, soil, this kind of thing, if we take care of the iron deficiency, we can take care of this problem. And now we go back to look at the infant, how infant can have iron deficiency. Iron deficiency of the infant depends on how much. If mother have iron deficiency, child can have also double iron deficiency. And also gestational age. Premature child can develop iron deficiency very quick than the full-term infant. And during the birth, before and after, if he lose blood, he can develop iron deficiency anemia too. And premature child usually risks to develop iron deficiency anemia within 3 months after the born, if he is not taking any iron in his food and he is only drinking milk. Usually the full-term infant can develop iron deficiency anemia after 5 months old if he is not taking any iron in his food. Where iron is absorbed in our GI tract is in the duodenum, and it can absorb up to 4 grams. But if someone is losing iron more than 4 grams, like say he's losing a lot of blood every day, he has a colon cancer and he's losing blood more than 4 grams, like say he's 6 grams he is losing iron, so he can develop iron deficiency anemia. So again we go back to just give a little discussion about iron deficiency anemia. Red blood cell will be in poikilocyte, anisocyte. This means anisocyte means red blood cell distribution, which will be greater than 20%. But in thalassemia, anemia of chronic disease, it will be less than 20%. So it tells us that iron deficiency anemia, red blood cell size will be start getting smaller and smaller and different shape of the cell. So only it can give red cell distribution will greater than 20%, but other cases like anemia of chronic disease, thalassemia, it will be below 20. And let me talk a little bit about again, just to remind you, total iron binding capacity. What is it? It's talking about the transferrin of the serum, and it's talking about the percentage it's saturated is talking about the capacity of it to carry the iron. And so now talking everything little bit of it, what is causing the hypochromic microcytic anemia? Again, iron deficiency, anemia of chronic disease, beta thalassemia, and lead poisoning, sideroblast anemia, and all of them will have reticulocyte will be low. Except thalassemia. So now talk about a little bit about, you give the parasulfate and now you are following this patient. You are thinking his mean corpuscular volume will come to normal, his hemoglobin will come to the normal, and you are following him, and you are following his reticulocyte. You found his reticulocyte come normal in 72 hours. This gives you signal that he is start producing the normal way red blood cell. But if it not become normal, reticulocyte not come normal in within 72 hours, and you can think something else causing the anemia, like has fibrosis in the bone marrow, he has low folic acid or vitamin B12 deficiency, and it's not the iron causing the anemia. You giving him iron and you are following him, and you expect that within a month his hemoglobin will come to the normal. His reticulocyte is normal and his hemoglobin will come to the normal within a month. But you found his reticulocyte come normal, but hemoglobin hematocrit is not coming to the normal. And you are thinking before he may have nutritional problem. But now his hemoglobin hematocrit is not coming normal, even if you are giving him iron. So you are thinking, oh, now he probably losing the blood. So for a child, you are looking for macula diverticulum. For an old patient, you are looking for colon cancer, which may cause him the iron deficiency anemia. So you are like, say, after a month his reticulocyte is normal, after a month you give the iron, reticulocyte normal, his hemoglobin come to the normal. So are you going to stop to give him the iron? No. Let to give him, because he already deplete his iron in his body. So continue this for another 4 or 5 months, so it can replace his iron level. And so after you give the iron, follow the patient with the expectation his mean corpuscular volume will be come to normal, hemoglobin will come to normal, reticulocyte will come to normal. Reticulocyte usually come to normal in 72 hours, hemoglobin come to normal within a month. And if reticulocyte not come to the normal, you are thinking iron deficiencies, then probably something else is causing. If his hemoglobin not come within a month and he is not the iron deficiency anemia due to the malnutrition, probably his iron deficiency anemia due to loss of the blood. and continue to give him. Even he develop after a month his hemoglobin hematocrit come to the normal and triglyceride normal. Continue to give him an iron for another 4-5 months. And so about the pica, we already talking about this. So in the if he take care of the iron deficiency, you will take care of the pica. He will not eat pepper, ice, all of these. And don't be thinking about the person psychiatric problem because trichomania can pull their hair and eat. But this is not the case in pica. Pica will eat the eyes and that this kind of thing. Okay. Next time we will talk about the sideroblast anemia. I finish now the hematology part 3, talk about the iron deficiency anemia, and I also talk about the list of the disease in microcytic hyperchromic anemia, normocytic normochromic anemia, and macrocytic anemia.